Good evening, everybody. Welcome to this EU IPFF webinar on optimizing quality of life in patients with pulmonary fibrosis. This is the fourth in a series of monthly webinars leading up to the first ever European Pulmonary Fibrosis Patient Summit, which is being held virtually on the 23rd to the 25th of April. And you're all very welcome to attend. My name is Steve Jones. I'm the president of EU IPFF, and I'm also chair of the UK patient organisation Action for Pulmonary Fibrosis. Tonight, it gives me great pleasure to introduce Dr. Marlies Wijsenbeek from Erasmus University Medical Center in the Netherlands, who's both an active member of the EU IPFF Scientific Advisory Board, and she's also one of the leading researchers on pulmonary fibrosis in Europe. Over the last year, I've had the pleasure of working with Marlies on a number of different projects, and she's brilliant at everything she does. So when I asked her before the webinar for a secret about herself to share with you all, she told me she's a terrible cook. And I'm afraid I honestly didn't believe her. I guess what she meant is she's not yet a Michelin-starred chef, but I'm sure you're a great cook. Anyway.
I'm terrible, to be honest.
Great, Marlies. I said, well, you gave me the news. Anyway, Marlies is going to talk for 25 minutes, and we will then have a Q&A session of about another 25 minutes before closing by 2000 European time, 1900 in the UK and Ireland, and in Portugal. So could I please ask you to submit any questions you would like to ask using the Q&A button at the bottom of the screen. The Q&A button, not the chat function. When you submit your questions, please write them as complete questions and as succinctly or shortly as you can. Please don't write general comments because it's going to clog up the system and then we won't get to the questions that we want to have asked. If there are any questions tonight which we don't have time to answer, Marlies has kindly offered to provide written responses afterwards, and these will be available on our website. The webinar today is going to be recorded, and it will be available soon on our EU IPFF website in English and with subtitles in 5 other European languages. We had hoped to be able to offer simultaneous translation in Greek tonight, but unfortunately that hasn't been possible to arrange. I'm so sorry to anybody who's logged in from Greece. I think that's everything. So without further ado, it gives me great pleasure to welcome Marlies and invite her to talk to us about optimizing quality of life in patients living with pulmonary fibrosis. Over to you, Marlies.
Thanks, Steve, and thanks very much for your kind introduction. It really is a pleasure to speak here, and it's a pity that I cannot see and meet all of you. That would have been even greater, but on the other hand, it's quite convenient to attend something in this way. I was asked to talk about optimizing quality of life in patients with pulmonary fibrosis, and I saw this picture on the website, and I do think this really breeds quality of life. These are my disclosures. I collaborate also with industry, but I never personally receive any money from them. And I think that is always important to know with who you collaborate. There are 3 topics I would like to touch on today. What determines quality of life for patients with pulmonary fibrosis? How do we measure it? Because if we want to do something with it, want to research it and improve it, we need measures. And how can we improve, and what is the evidence so far? And I think quality of life is something that is very intangible. It is so different for many people, and this is a very old concept from Maslow, already from the 40s, about what determines your needs in life. And first of all, it's the physiological: breathing, food, water, your health, your security, your family, your property, friendship, love, belonging, esteem, confidence, and self-actualization. And you can already figure out some of these things are very much influenced if you have a disease, and especially if you have a disease that might be progressive, have a lot of symptoms. But it also means that it is difficult to improve things because things interact. And that's also what I hear, and you might recognize yourself. There's so many ways that a disease can influence your life. Some people say, I'm tired, I'm more easily upset. The others say, I cannot work in my garden, I'm really short of breath. I'm worrying what will happen if I'm not here anymore. I worry for my family. I have cough, I feel embarrassed. I don't dare to go to my card club anymore. So it is so many things that may play a role. And besides that, we have many forms of pulmonary fibrosis. And I'm quite sure that there will be people out there with different forms of pulmonary fibrosis. And that also translates to different disease behavior, different symptoms, and different progression. And this is only a picture of IPF, where you already see that how the disease behaves can be more slowly, it can be sort of average, it can have acute exacerbations, can be rapid. And this is within one form of pulmonary fibrosis. And the same actually holds true for other forms of pulmonary fibrosis. If you look in rheumatoid arthritis and ILD fibrosis, you see that there's different disease behaviors. The same applies for systemic sclerosis, and I could show you pictures of many more fibrotic diseases that all show a wide range of disease progression. So here you see that sort of summarized. On the bottom, you see the disease behavior from reversible diseases to rapidly progressive and anything in between. And we're all different and people are different. So some people will have more or less stable disease or episodes of stable disease, and other times it will be progressive, and sometimes it will be rapidly progressive. And that has major impacts on quality of life. And what are the most common symptoms, the most common and presenting symptoms? And these are data from two registries. On the left is an American registry, where you see that shortness of breath, cough, and fatigue are the major presenting symptoms. And this is a German registry, where it's similar. So across the world, patients with pulmonary fibrosis do experience a sort of the same symptoms. And there's also been research on what these symptoms mean for your quality of life. And this is the Australian registry, another part of the world, where you see, and they showed that besides the lung function, the shortness of breath, the cough, and anxiety were major drivers, so major determinants of quality of life. And this was a study in idiopathic pulmonary fibrosis, IPF. And also, if you compare it to the general population, so people from the same age and sex in the same country, you see that in pulmonary fibrosis, the quality of life measured with this is a quality of life scale is lower than the reference value for the whole population. So here you see in Germany that the reference value is almost 0.9, and it's 0.668 for patients with pulmonary fibrosis. This is in the US. What is striking is that the general population has a lower quality of life than in Europe. That is encouraging for this European meeting. But also there you see that patients with pulmonary fibrosis have a lower quality of life. So the more reasons to see on how we can improve or maintain this. And let's not forget about the system around someone, the family, the partners. And this is a survey we did in our patient population, and it's a screening tool for anxiety and distress. And we asked both to the patients on how it was with your ability to relax, and to their partners, or if they brought a child, or but the person that came with them. And what you see is that there's not so much difference between the two. So the majority of people do have troubles with always relaxing, and it's not different. So having a spouse with a disease like pulmonary fibrosis also impacts the well-being and the worries of the spouse, or of the father or mother or the child. So I already said, how do we measure quality of life? Because if we want to improve something, you would also like to measure it to see if you actually improve it. And this is what many of you know from your visits, I think, to the hospital. This is pulmonary function that is performed every time. And here you see a curve of one of the patients in our clinic, where you see that it sometimes goes down, it's a bit more stable, but in the end, the trend is down. And we make also imaging CT scans. So these are things that we as doctors are very familiar with in following up patients and seeing how things are going. But that is not capturing how your quality of life is. It is a bit, because if you have less lung function, it impacts how you function. So it impacts what you can do and it impacts your quality of life. But quality of life is much more. And all these factors are related to each other. Because if you cough a lot, you can have these bouts of cough and get very dyspneic. That may cause that you're anxious. You may worry about that if you will get it again. It will also cost a lot of energy because it takes energy, because you start coughing when you move. You try probably to avoid that. That will decondition you. So all these things are intertwined and work together, and together determine your quality of life. And then there is another thing. We're all people, and all people are different. And we know that for some people, the glass is always half full, and for others, the glass is always half empty. So symptoms, reactions, and perceptions interact. And also your personality and how you cope in general with things play a role in how your quality of life will be. So that makes it that we have to develop tools to really measure it. And like I said, what we are used to use in clinic is physiological outcomes. So this lung function, a 6-minute walk test. What we do more and more now is these outcomes measured or recorded by patients. So we have home spirometers where you can blow spirometry at home. You can measure this oxygen saturation at home. That's becoming more used. And we're also, I think, asking more about symptoms to patients. So using VAS scores or numerical scores. But I think everybody who's participated in research, and some clinics already do this in daily practice, know that there are questionnaires that ask about health-related quality of life. And if we take it even one step further, and that is more and more in development, it's patient-driven outcomes. So these are questionnaires and measurements that are developed together with patients and are chosen with patients, what should be in and what is important and what should we measure. And all these last three we call patient-reported outcomes. And that is a term you will see a lot, patient-reported outcomes, because that is really about how you report directly, how you feel and function. And I'm not going into all details, but for people who have filled in these things, there are different sorts. There are generic ones you can use for a whole population. There are disease-specific ones that you can use for IPF or other fibrotic diseases. And there are questionnaires that even ask very specific about one domain, so about dyspnea or cough or medication. So that brings us to, I think, the most important part on how to improve quality of life. And this survey was done together with the EU IPFF and the European Reference Network for Rare Lung Diseases, the ILD group there. And it highlighted priorities, unmet needs for patients with pulmonary fibrosis and their caregivers. And you see that timely and accurate diagnosis is important, information, symptom relief, access to specialists, psychological support, involvement of partners, non-pharmacological support, so oxygen, pulmonary rehab, access to a multidisciplinary team, and end-of-life care. And we built in our system an ABCDE of care, which is based on all these needs, and which is a continuous process because we keep improving it with feedback from patients and feedback from the team. And the A of is from assess. So assessing, is the diagnosis correct? Is this the best place of care? Because sometimes you don't have to travel to a specialist center, other times it is necessary. Is it in line with patients' needs and values? It's important to see patients as partners in care, so share decision-making and also include the caregivers. The B is about backing, and I'm going to talk a bit more about that because we're actually doing backing now, giving information. It is about education, and education, I think support groups can play an important role. Internet and information is getting better and better online, but you have to be critical. But support group information is checked and is accurate. We also know that it's highly beneficial for some people, but maybe distressing for others. And it has been focused quite much on IPF in the past years, but that is improving. And then it's about self-management. Logically, you ask, what can I do myself? And if we think about prevention, there's not so much we can do, but we know that things may trigger and keep fibrosis ongoing. And one of these things is smoking. So hence, everybody's encouraged to stop smoking if you'd still do that. And we also ask to keep your environment as clean as possible. If you would have a job with very much exposure, we advise that you should probably change and quit that job if that's possible. We also say, try avoiding a mechanical stress. That's a bit cryptic, but what it means is that we know if you have more clear and overt fibrosis, that mechanical ventilation, so for instance, with an operation where you get a tube and a machine will take your breathing for some time, may really stretch your lungs and may have a risk that the fibrosis will deteriorate. So if there is a possibility, for instance, if you break your ankle and you could have a local anesthesia, that would have the preference. We also advise influenza, pneumococcal, so infectious vaccinations, and currently also the COVID-19 vaccination. There's not much research about these recommendations. It's based on expert opinion. And we talked about my cooking skills, which I really am going to disappoint Steve, but my cooking skills are awful, but I do like good food. But I have a husband that is an excellent cook. And diet is something that is important. We only have indirect evidence, but we have seen in several studies and registries now that people who lose more weight during the fibrosis do worse. And here is a cohort from the UK where you see that the survival in patients with weight loss is less than the survival in patients without weight loss. And what you see on the other side, the blue bars are the patients that got the sham, the placebo in a trial. And these are the patients that have more than 5% weight loss. And you see that they lose more lung function in a year than the patients that didn't have significant weight loss, less than 5%. And how this exactly works, we don't know yet. And we also have not done a study that if you send everybody to a dietitian, if that positively influences lung function and outcomes. But currently, we all advise if you lose a lot of weight and cannot manage to eat that yourself, to go and see a dietitian. And then there's the oxygen supplementation. Also here, it is not, all recommendations are not all based on very good research. Much of the research is coming from other areas, from COPD, for instance. But at the moment, it's the clinical advice and opinion, and there have been very recent international guidelines about this to recommend supplemental oxygen in rest. So if you sit, if your oxygen saturation with the pulse oximetry is below 89%. We have not done research where we gave half of the patients oxygen and the other half not, and then after a year asked how quality of life was and how survival was, because we think that is not ethical. So I don't think we will have that, but this is now the international recommendations, which you could also use and show to your doctor if you would want to discuss this. There's more research, and this is a very elegant trial done for ambulatory oxygen, and that's oxygen when you exercise, when you walk. And this was done in a group of patients that had low oxygen, so below this 89% when they walked, but were still on with good saturation when they were sitting. And when these people used oxygen compared to patients that did not use oxygen, so they draw numbers, half of the patients got oxygen and the other half didn't. The group that had oxygen had a better quality of life measured with these questionnaires, and also was less breathless. You see here that the group that said I was better was very high in the oxygen, and worse was in the no oxygen group, or the same. So using oxygen on exercise does improve breathlessness and does improve quality of life. And that brings me to pulmonary rehabilitation or physiotherapy or whatever is available, but to keep active and moving and train. It's been shown that this is safe for people with pulmonary fibrosis. It's also been shown that it improves the short time exercise capacity, so how much you can actually exercise and walk. It decreases the dyspnea and it improves the quality of life. The problem is that if you stop doing this, the long-term benefits will go down. So there's very little evidence on how long the effect will stay after you stop. And nowadays, I think self-management is also about things online. Many of you will be online because you're also in this virtual meeting, so you probably have devices. And more people have started using home spirometers apps to keep track of their symptoms. This is a quality of life score and their lung function, and use activity trackers and step counters. There have been actions also with that. And what we did in the Netherlands is that we randomized, which means we again drew numbers. Half of the people got a home monitoring set, so with the home spirometry in the app, and the other half didn't. And after 24 weeks, half a year, we looked at the quality of life this had for patients. And what we saw is that the quality of life seemed better, and especially the psychological well-being of patients. It didn't change much in the breathlessness, which is kind of logical because you got an app and a spirometer to look at how you're doing. There was no exercise involved. And what was important is that the patient experiences are very positive. So the majority of patients would recommend it to others, said, I have better insights in my disease scores, I feel more secure, and I have better lower threshold communication with the hospital. And that brings me to the last item in this backing category. That's about trial participation. The only way we can advance the field and get new drugs and get new support measures is if we collaborate with the healthcare providers, the researchers, and the patients. And here it is a survey where they asked, did your doctor ever offer or discuss with you trial participation? And we see that about half of the patients knew about this, but the other half didn't. I do think it is important to know about trials. You can always decide whether you want to participate or not, but if you don't know what's going on, you also have no choice. And we do know from research that patients that participate in a trial report that they were more hopeful, felt more empowered, and felt they contributed. So in the end, these patients, even independent of the intervention, felt better. And I go to the C, which is the C of comorbidities. And I'm not going to talk about that because Professor Kreuter, Michael Kreuter, talked about that last month. And there's a beautiful talk on the website, which I would recommend you to have a look at. The same applies for the disease-modifying treatment, so the antifibrotic drugs. For some patients, immunosuppression, and for a small group of patients, even lung transplantation. That is outside the scope of this talk. And that brings me to the last topic, the early palliative care. And palliative care has a name in it that scares people, because you associate palliative care with end of life. But I do think it is important to realize that the definition and the goal of palliative care are to prevent and relieve suffering by controlling symptoms and to provide support to patients and families in order to maintain and improve their quality of life. So it is about supporting and about comfort and improving quality of life. So I think this naming is not always very, easy naming. And we usually talk about comfort care or support care. And if we look at one of the symptoms that I showed also in the beginning that is important and that may increase during the disease is the breathlessness. And what we always first do is look, are there other causes for breathlessness? Because it's not always the lungs. Sometimes it's the heart, sometimes it is deconditioning. So sometimes there are other things. We recommend pulmonary rehab because from pulmonary rehab, it's really been shown that it affects breathlessness positively. I've also shown you that oxygen, especially oxygen on exercise, helps for breathlessness. And there is what we use in practice a lot is opioids and benzodiazepines. Some patients tell benefits about that, others don't. There is small research about it, which is not always pointing in the same direction on the effect of this. So this is more a trial and error without very good evidence in pulmonary fibrosis, but it might be worth to actually try it if you struggle with dyspnea. There is always a bit of scare about the use of benzodiazepines and opioids. Sorry for the noise here. I have 3 boys running around and they make a lot of noise. But it was shown that it was absolutely safe, that it was not associated with complications, not with hospital admissions, not with mortality. And that brings me to the next symptom, which is cough. And cough is a really frustrating symptom, both for patients as well as for doctors, because there's no good evidence-based therapy in IPF. What we first do is exclude other causes, like some medications may cause cough, postnasal drip may cause cough, but then it is just trial and error. Over-the-counter cough suppressants, codeine, steroids in a very low dose, acid suppression for the reflux, speech therapy, some effects, some sort of painkillers, and also opioids again. But I do want to tell you there is hope. There is some drugs now coming from chronic cough or coughing cancer that seem beneficial in those areas, and the pharmaceutical companies are starting to investigate these also for fibrosis cough. So I hope that if I speak to you maybe in some years again, I have better news about this. And then the end of life. And end of life is difficult to talk about, not only for patients, but also for doctors. Doctors also think, how should I bring this up? And because I also struggled with this personally, I surveyed my patients and I said, when would you actually prefer to talk about matters concerning end of life? Would that be more early in your disease, or would that be when you have more advanced disease? And what you see, and we also did that in Germany, that differs per patient and also per culture and per country. But I think you should not be scared of bringing this up with your doctor, and you have the right to ask about it, because sometimes you have worries that are not necessary. So discuss your worries, make your wishes clear, make your limitations clear. Tell the doctor what you need and don't be modest. These are things that you really should share, and we're there to support you. And then another driver of quality of life is anxiety. And it is logical to have worries. And not always we can help, but there are some programs and ways we can help. So please discuss this as well. This is a mindfulness program that's helped, and this is a patient empowerment program, which is a group program with all disciplines involved, but also peers. And I think also with peers amongst each other, you can actually help each other. So this is the summary actually of what I just told you. And I think the good thing is that you should realize that it is always changing, and it is changing throughout your disease course. So please keep reassessing it, keep discussing it with the nurses, the doctors, or anyone involved in your care. So what I just talked about is what determines the quality of life for patients with pulmonary fibrosis. And this is very individual, but we know that symptoms like dyspnea, cough, do influence your quality of life. Loss of function influences, and also worries. How do we measure it? We ask the patients. I think you're the most important in this, and please feedback on what you need, how we can help, and if things work or don't work. And how to improve. The ABCDE of pulmonary fibrosis care is not the way, but it is a structure. And I think it's important to see that there are many options and dimensions that you can touch on and discuss with your doctor. And also, I'm going to be honest, there's much more research needed on how we can do better in symptom relief and how we can better support you. So that brings me back to this important pyramid of needs. And I think this is something you're in together. You're in it with your family, with the healthcare providers. Optimizing quality of life is a team effort. So I thank you for your attention, and I'm very happy to take questions.
Great. Well, thank you very much indeed. I will, before we go to questions, just let people read this to say the registrations are now open for the European Pulmonary Fibrosis Patient Summit. go to our website. Here's the link. You can find it quite easily and register if you'd like to come. You'll all be very welcome. Patients, carers, doctors, healthcare professionals, industry, everybody welcome. Great, thanks a lot. Marlies, that was absolutely wonderful. Thank you.
I'll stop sharing, is that okay?
Stop sharing now, that's fine. Great, and I see, so that's good. We've had already a number of really interesting questions come in. The first one is from a UK patient who's had IPF for 6 years. He says, IPF seems close to COVID-19 and long COVID, with some similar symptoms, such as declining breathlessness, coughing. Will any of the vaccine research lead to further insights into alleviating IPF, or even to new alternatives to the only 2 current available drugs, nintedanib and pirfenidone?
I think it's a very clever question. I'm not sure if the vaccines will actually lead to more insights in pulmonary fibrosis. I do think that the post-COVID phase, so how the lung behaves and why do some people get scarring of their lungs and have abnormalities after COVID, and how does the immune reaction during COVID work, why in some people it resolves and why do some people get more sick. I think these things can help us also get more insights in why people develop fibrosis and how it works. So yes, I do hope that we will learn from that actually. Yeah.
Great, thank you. We have another question on, for thanking you for your insightful and empathetic presentation. Many patients, especially early on in their diagnosis, spend very little time with the healthcare professionals. You're diagnosed quickly, a quick conversation with a consultant. If you're lucky, you then talk to a specialist nurse. But so they prefer to turn to peers for practical advice and for emotional support, which is great. But do you know of any studies that demonstrate the value of peer support?
No, the only 2 that are is there were that's peer support but moderated in a hospital. There's one of Kathleen Lindell from the US where she had peer support groups and looked at the effect on quality of life, which strikingly actually was sort of negative because people got very worried. We did the same with this peer support group, but it was moderated by a psychologist and there was a physiotherapist involved, and that had a positive effect on quality of life, but it was not an independent peer group. And I know that in the UK, for instance, they're very well functioning peer support groups, and I think it would be most interesting to actually measure. You could actually do that yourself. I'm very happy to provide you with questionnaires on beforehand and afterwards. I think it will be a unique project to actually look at the effect of peer support groups on quality of life. So excellent idea for new research.
Okay, well, putting my APF hat on, we'll gladly accept your offer. Okay, but related to that, one of our support group leaders actually in the UK says research suggests, and he would agree, that some PF patients find support groups difficult to join. The activity is, they're not actually happy with the activity. I know I myself, when I had IPF before my transplant, I was very reluctant to go to a support group. I think I always say that I was scared of going into a room full of sick old people who look just like me, and that sort of thing was certainly an issue. This guy says, do we know why this is the case? Why are people find it distressing? Is there anything we can do to address this?
Yeah, I think one of I think at least 2 or 3 things I hear from, because we direct patients, we don't have these very independent support groups in the Netherlands, but we have a very strong patient association with big meetings. And we have patients that tell me, no, I don't want to go there. And if you ask why you don't want to go there, there's 2 main reasons why. One is I don't want to be confronted with my disease. I'd rather not spend as little time as possible thinking of my disease. And the other one is I'm afraid that I will see how I will be in 2 or 3 or 4 years. Yeah. So seeing your future. So I think that is the main arguments I'm hearing back from patients why they're not going. I think the first one, not wanting to spend time on your disease, I don't think as a support group you can do anything about that. The second one, you can probably mitigate a bit. You can probably have different support groups for different, types of people.
I think there's always going to be some people who don't like joining groups like that and want to be alone.
I think that is for everything. Not everybody wants to
sure.
do something in
but,
a team.
Some people like me, actually, when you join one, you suddenly become a born again support group, you realize the benefit of it. So yeah, we're all different. An interesting question here, which is one that I know lots of people talk about, lots of patients talk about. My SpO2 levels at rest are about 95%. If I walk upstairs, I get very breathless, and my levels can drop to less than 85%.
Yeah.
Is there any research on the impact of short periods with levels less than 88% or 89%?
No, there's actually not. We are, what we know is a bit from other fields like COPD or other fields, that patients who are very low on oxygen in their oxygen levels the whole day, if they use oxygen for more than 15-16 hours, that may prevent getting pulmonary hypertension. Because if you are low on oxygen, the vessels in your lungs will constrict. So the right side of your heart that pumps the blood through the heart will have more to generate more pressure. If that is influenced by short bouts of low oxygen, we don't think so. But we've never looked at what will be the threshold, how many hours you should be in low. But probably that is at least at half of the day on low oxygen. So not this just short walk on the stairs.
So what we're told about, we shouldn't let oxygen go for prolonged periods below 88% because of damage to organs. What's the mechanism of that damage? How does it come about?
I think in all these things is that there is shortage of oxygen. So also people have cardiac problems who have coronary artery disease. We know that some people report that they get actually more heart complaints if they're longer on short of oxygen. So I think the general oxygen supply to some organs is low at that moment. So I think that is the rationale on not making that period endless. On the other hand, I also see patients in my clinic who are constantly at 87% who say this oxygen, no use to me at all. I don't feel anything. What do you recommend there? Do you have to wear it if you hate it? And, in the end, it is what you decide also yourself, what improves your quality of life.
Yeah, okay. Well, I was wondering the question about, you showed lots of graphs of how with home-based monitoring people who did it led to improved quality of life. Participation in clinical trials led to improved quality of life. Did you control for the fact that it may be that optimistic people who, actually are the people who adopt these technologies, or they go for a trial, they adopt a technology? Is it that just certain kinds of people take them, and therefore the science is not as clear as?
Yeah, I do think there is a bias in these things, because people who embark on trials are a selection in general, not always, but still within this, these people are measured before and afterwards, and they are compared to people who didn't do it, who are this same optimistic group, because they had to draw numbers. So the people who got in at the same are from the same optimistic mindset, maybe.
Yeah.
So I do think that corrects for it. So I do think this generally may impact. On the other hand, I also have to be honest, because we did only 24 weeks of home spirometry. I'm not sure if you still like it so much if you do it for 3 years. We've never researched that. So if that still improves. So we have to do these things longer to know about that.
Yeah, for sure. I have a few friends who have done that, so I'll ask them. They could even be on the call. An interesting question here, which is a UK-based one. It's, we have a constant, we're trying to campaign with NICE in the UK to remove this rule that you can only be given antifibrotics with IPF once you drop to 80%, and when you get down to 50%, you're taken off it again. And the question from a specialist nurse in the UK is, in Europe, do more patients get put on antifibrotics earlier?
Yeah.
In other words, okay.
Yeah, I don't want to frustrate you, but the answer is yes, because what we know is that, and that is, I really think NICE made a mistake in this. And I think you're absolutely right in the UK that you're battling in this. because you could have started on 110% and already lost some. And we also know that the speed on how you would lose on average is probably more or less the same, whether you start off on 90% or you're on 60%, the rate of what you will lose is not impacted. So I do think that NICE has to reconsider these criteria, because with the current evidence, they really make no sense. People should have a choice. You can decide yourself, I'm still on 95%, I don't want to start, but at least you have a choice then.
Yeah, in fact, there is potential. We hope, we've got fingers and toes crossed that we might hear some good news shortly, that NICE is in fact has reviewed the evidence, and we hope that that review is going to say they should now repeat the technological assessment and see whether the rules need to be changed. And we've been lobbying hard for that for a couple of years. So let's hope it.
I keep my fingers crossed for you, and I'm happy to support it. Should you?
Well, we may well come to you for examples of practice in Europe. I think in some European countries, we do hear stories of doctors maybe not prescribing immediately on diagnosis. There's still being a bit of a wait and see culture, which obviously is, again, not.
Yeah, no, I can imagine that sometimes you wait and that sometimes patients choose to wait, but I think you should be informed and have a choice. And if you decide then as a patient, I would like to see how things are before I'm convinced, that is fine to me, because you have a lot to take in at the beginning. You have this diagnosis, you have to grasp that, but sometimes it takes 2-3 months before you can make such a decision, which is fine, but at least you have a choice then.
Yeah, I know so many patients who have been waiting 2 years. And we now have the added problem with COVID that it's difficult to get a lung function test. So you can't prove that your FVC has come down to 80.
Yeah. And their host spirometry might help, because you could actually show my curve is going down. Yeah,
I think that there's insufficient discretion given to clinicians in the UK.
In the UK, there will also be a home monitoring trial starting, the iFile study, in several centers. So I hope that will give access to home spirometers that you don't have to pay.
Thank you. Okay, an interesting question here from a non-IPFF patient. It says many medications for NSIP, and this would apply equally to things like autoimmune connective tissue disease. Those treatments being steroids, mycophenolate, one, two others, have side effects. Is it difficult to work out which one causes what? And I'll put in a slight change to the question, say, do we know that those treatment regimes work?
I think it depends a bit on the disease. There is for several diseases, there is some evidence that the drugs work. It is not always a randomized trial, but it may be good circumstantial evidence. But there's also for many diseases no good evidence. In general, we know that diseases like polymyositis, dermatomyositis, scleroderma. So there are several diseases respond quite well to immunosuppression, different forms of immunosuppression. We also know that really UIP, so really honeycombing fibrosis in these diseases, which is a bit further advanced, usually doesn't respond anymore and is probably more prone to respond to antifibrotics. About the side effects, as doctors, we know quite well the profiles of the side effects of the drugs. So we can usually pretty well distinguish and discuss with you if it is contributed to this drug or not, and check it in your bloods. If we would add an antifibrotic on top of these immunosuppression, which is a possibility, and I don't know if it's yet in the UK, but in our country it is at least, and we would always make sure that you would be stable on the one drug before we would add another one.
Great, thanks. Now, in the UK, the assessment is going on of nintedanib for a non-IPF pulmonary progressive fibrosis. Decision expected in September.
Okay, and we just had it approved in the 1st of February, so it's very recent in our country.
Yeah, sure. Okay, great. And thanks for an interesting presentation from Norway. A good question coming. Why isn't there any new research on lifespan? And I think there is actually, you can tell us about it. All online information still gives you 3 to 5 years, which is pretty scary when you're newly diagnosed. Do we have confidence now that certain patients with nintedanib, with pirfenidone, with improved other treatments are living longer? Because there was a publication, I think, last year, CORE.
We have several.
Years. Yeah, it's still 4 years, yeah?
I don't know, but there are several publications, at least from registries, showing much better survival. So There's been the German registry that showed that patients on antifibrotics lived longer, had better survival. There's been the Eastern European registry that has shown that people lived longer. And there's also been modeling based on the data of the pharma trials to see how much time you would gain with these drugs. And that was also significant, varying from 2 to more years even. So I think there's lots of evidence building now that when you slow down the lung function, it leads to living longer. And it's also what I see in my clinic. I fortunately have patients much longer in the clinic. Nevertheless, some people respond better than others, and some people do remarkably well for years, and others do not. So we cannot predict very well at the start who will do good or who will not.
Yeah. And is it correct? I mean, we usually give this 3 to 5 year, doctors give us this 3 to 5 year window for IPF. But if we look at the other things like chronic hypersensitivity pneumonitis, farmer's lung, or hot tub lung as well, that can have a wider range. I mean, the median might be about the same, but can kill you quicker or slower. And it's got
I think in general, it is for the whole population, it's better because there's people who reverse, who will stabilize, and there is a subgroup that will be progressive. And once progressive, with these criteria that were in this INVO trial, they more or less will behave in the same way as IPF. But these groups are much more diverse. So they include a group that does very much better than IPF.
Yeah, I mean, there is, I was reading an interesting thing by our friend Raghu from the USA, talking about IPF in a sense being not a disease at all. It's rather the end state of all fibrotic diseases. And I think it's an interesting kind of way of looking at it, but the point being essentially that the end stage for all the diseases is very similar. Patients experience it in the same way.
I think once, there's many triggers. There is things inhaling, there's autoimmune diseases, there is genetic factors. So there's lots of things that can cause a reaction that in its turn can either resolve, stabilize, or progress to fibrosis. And once you have this progressive fibrosis, then it doesn't really matter anymore what set it off at the beginning.
Yeah. Okay, no, that's very helpful. Would it be possible to elaborate a little bit more on the mechanical ventilation point? I mean, I took from that the idea that really one should avoid an operation involving a general anesthetic. Would that be correct?
There is some data, and we know that if you put someone with fibrosis on mechanical ventilation, that you have a risk of exacerbation. Not everybody, but there is a risk of an acute exacerbation, so deterioration. And there's been very elegant, by Martin Kolb's group in Canada, experiments where they took lung tissue that was fibrotic and they stretched it in a little bath in the lab. So they did the same as what you would do with a mechanical ventilator, stretching is, and it showed that there was a release of pro-fibrotic mediators. So things in the blood that would actually drive fibrosis. So probably stretch, so mechanical stretch, will induce a more pro-fibrotic profile in your lungs. And this is all new and theoretically, but it does explain what we see, that if you mechanically ventilate patients with pulmonary fibrosis, a percentage of these people will deteriorate and not get off the ventilator anymore.
Great. Yeah, no, thank you for that. Question, another interesting question here. In your opinion, what causes weight loss in pulmonary fibrosis?
Yeah, I think that it is a very good question. I think there might be several things. There might be the extra energy you need for the breathing, but there might also be the side effects of medication, that you have less appetite, that you might have diarrhea. Shortness of breath also causes less appetite, so that you eat much. And maybe there is also a sort of metabolic or catabolic mechanism, so that factors in your body actually make it more difficult for your body to keep your weight, and that it goes down because of chemical mechanisms happening in your body. So I think there are potential several ways. And the ones you can influence most easily is obviously trying to mitigate the medication part, and the intake part get more in.
Okay, yeah. I mean, I often, personally speaking, my own experience, that was an end of disease problem for me. But I mean, for many people with IPF are in that group of, when we look at the COVID, older, white men, often overweight, diabetic, etc. Yeah, it's a risk category. And I was surprised that IPF patients were generally fell in that category. But I suppose in that way, for people who are overweight with IPF, losing weight early on in the disease is a good thing because it will make you less breathless. Would that be correct?
We don't know that, to be honest, because if you would look in the trials, the people with a higher BMI would actually do not so bad. So I don't want to advocate that you should be too fat, but losing weight is not always positive.
So it's not really an issue. Is it an issue throughout, or is it an issue that we think about mainly at the advanced stages?
It happens more in the more advanced stages. Absolutely, we see it more there. But we need, I think, more research on how you could influence that and how it would impact prognosis.
Great. Okay, that's fine. Thanks. You've got a lot of you've got a big fan club in Greece, I must say.
Thank you.
They haven't asked a question, but they've given you lots of nice compliments. And then a person here says, I find patients who have ambulatory oxygen get distressed as they check oxygen levels at home and they appear to be low. However, they've got finger clubbing. And when I check it in the hospital on a forehead monitor, it's within normal range. Have you got any advice regarding reassurance to help patients relieve worry when they're exercising remotely?
Yeah, I think there's practical things with these meters. If you have warm hands, they do better, and you have to make sure that you have this nice curve and pulse on it. So that's the practical part of it. On the other hand, I think you can also trust your feeling. So you don't have to measure all the time. If it does feel okay for you, just trust it. Some people do without and also do well without meters and also manage well. So I think it depends also a bit on your personality, if you want to have numbers or if you trust on your feeling.
Yeah, there's a related question coming in, same thing. So what would you recommend for a patient who does not benefit from using the technology, oximeters, etc.? They become obsessed with it. And it increases their anxiety about going below certain levels of saturation. I was one of those, actually, and ends up worsening quality of life instead of improving it. So in other words, the technology, is it better then when you have remote monitoring to have blind monitoring, where the statisticians
it might be for some people. We offered in our tool that you could switch it off, that you could not see it. No one did that. So people are curious, I think. But I can imagine that it may worry you to see these things. And I think we have to learn about it. And I think you have to be realistic yourself. If you see it, just, throw this meter out and think, I'm going to enjoy the moment now, and I'm not going to measure it all the time. Because it should not make you unhappy. Then it's not the right tool.
The right thing to do, yeah. I mean, there's a similar question here, one which people feel very often. Is there any evidence that starting on oxygen therapy makes a patient need more oxygen sooner? I don't understand if my increase in oxygen supply prescribed by my specialist would have needed to be so substantial if I had not been put on oxygen therapy in the first place.
No, there's no evidence for that. No, it's not that you become addicted to oxygen. Most people do like it and feel more comfortable, hence they keep using it. And unfortunately, there's many cases that the disease declines, so that you do need incremental oxygen levels.
Great, thank you. Another question on cough, because this is really important. I mean, there are a number of cough drugs in the pipeline, entering into, hopefully into phase 3 trials soon, which may become available. One of the issues I had when I lived with the disease was asking, well, what's the cause of cough? And there was no answer. I mean, do we know, with these drugs that are being developed, are they being developed for specific known causes of cough in IPF patients or PF patients in general?
What we think is that the cough is more a neural thing, so that you have these sensory nerve endings in your lungs, and probably the IPF stretches them and makes them more sensitive. So that a minor trigger, you laugh, you move, you exercise, already sets, there's even research, if you shake someone's body, they start coughing. So this threshold to set off these cough sensory nerves is lowered. And there's also something that probably the threshold to detect it more centrally is also lowered. So that causes the cough. So all these new drugs, promising drugs, actually do what on this signaling of this cough. And that seems the most common reason for cough in IPF, this irritating, dry, easily set off, tickling cough. There is a small group of patients who have more bronchiectic cough, so they have sort of more mucus in their lungs and cough because of that. But there has been cough studies done now with antibiotics, and that was negative. That didn't really work. So I believe personally more in these sensory nerve influencing.
Okay, so I mean, would another related question here? Would then, the over-the-counter remedies basically are not really effective?
In some patients, they work amazingly well, so it's always worth to try it. Even codeine does work, and you have other, I think in other countries you have other things that you can dextromorphin, I think it is in the UK, can try. So I should definitely try that. What we also sometimes do is just an inhaler with nebulized salt. In some patients that also works, but it's trial and error. It is different for each patient.
Okay, yeah, I think it is. Well, look, Marlies, I think we'd better begin to wrap up. There are a few small unanswered questions here, which are important. There are lots of huge compliments about what an interesting and informative webinar. So thank you.
Thank you very
much on behalf of all of us for an excellent talk and for stimulating that discussion. I think we could go on for longer. I mean, it's pity we can't unmic people so that they can really join in. It would be great. Let me just double check there's not one last one. No, we've been through the whole lot. So thanks very much to everybody who answered questions. And the person who actually put in the most questions of all has just said, thanks so much, it's been great. And she
thank you very much. It was a
lots of comments as well as questions.
And I really miss it that I don't see all the faces. That would have been great.
Over 100 people joined the webinar tonight, which is great. We hope you've all enjoyed the evening, and we'll come to the first ever European Pulmonary Fibrosis Patient Summit, 23rd to the 25th of April. There are going to be 3 afternoons in a row, and there'll also be a couple of very interesting industry sessions. I can say that because I'm involved in one of them, but they are both really interesting outside the normal afternoons of the 3 summit sessions as well. And also in May, we're going to start again doing these monthly webinars, and we're going to probably even do some very topics of minority interest, maybe specific topics on disease types like rheumatoid arthritis, ILD, chronic hypersensitivity pneumonitis, provide a forum for people living with those diseases who don't usually get the same opportunities as people with IPF. Finally, I'd like to thank the EU IPFF Secretariat team as ever, Alba and Samantha, for their hard work on putting this together tonight. We've recorded the session as usual. It's going to be posted on our website. So if you really got nothing to do tonight, you can watch it all again, or at least maybe tomorrow night. And as I said, it's also going to be put on there within 2 weeks with subtitles in 5 other European languages. So many thanks to everybody for coming. Many thanks to Marlies. You can see Marlies again in a number of sessions at the summit in a month's time. Great. Have a nice evening, everybody. Bye-bye.
Thanks very much. Bye-bye.
Bye.